All right, so tonight we're going to be going through planning for an RSI and end-tidal CO2 monitoring. Now, you're going to have to be patient with me. You're going to have to use your imagination. I've been sent on relief and I've forgot all my stuff, including my computer. All right, so indications for an RSI is for patients who are at high risk of an aspiration, like patients with impaired gastric emptying, dysfunctional lower esophageal sphincter, patients with a decreased LOC and unable to maintain their own airway, patients with imminent airway obstructions such as anaphylaxis and burns, and patients with severe respiratory failure. And RSI is absolutely contraindicated in patients with a complete upper airway obstruction and any life-threatening allergies to any of the agents that you'll be administering. All right, so we're going to go through the steps for an RSI. First of all, we're going to start off by setting up IV access, 2 lines if you can. We're going to set up monitoring, pulse oximetry, cardiac monitoring, end-tidal CO2 monitoring, blood pressure, monitor their blood pressure as well. We're going to have a discussion with the team. We're going to plan the procedure with the team, identify the location of all the equipment, designate roles, and make known any potential airway difficulties that you've encountered during the assessment. We're going to then prepare all the equipment, including rescue devices, make sure we've got suction working, oxygen working. The next step after you've pre-oxygenated the patient is you're going to induce a sedative agent of choice, immediately followed by the paralytic agent, unless you're deciding to go with a delayed sequence intubation because you think the patient's at risk of rapid hypoxia, then you'll ventilate the patient after you've induced them. At the start of planning for an RSI, we're going to have all the monitoring equipment ready. Here we have cardiac monitor, we'll have the leads attached to the patient, pulse oximetry, blood pressure, end-tidal CO2 monitoring, mainstream, side stream, whatever you have available. We're going to want to then pre-oxygenate the patient. In the spontaneously breathing patient, we'll oxygenate them for about 4 minutes using non-rebreather, high flow nasal prongs, both at about 15 litres per minute. If the patient is not ventilating adequately, we might have to try some bag mask ventilation. We're also going to have to make sure that we have the suction ready, checked and available. Now the patient's currently being pre-oxygenated and the team's being briefed. We're going to want to have IV access, 2 cannulas in if possible, and we'll have some IV fluids running. We're going to have prepared the induction agents. We're going to have the doses cross-checked. So common induction agents, we can have midazolam 0.2 milligrams per kilo. We've got to be cautious that midazolam is not an analgesic, so we might have to consider giving something like fentanyl at 2 to 3 micrograms per kilo, but then we just got to be wary of respiratory depression and chest wall rigidity. We could consider induction agents such as propofol. It's more rapid acting, shorter duration, but we should be avoiding this induction agent if the patient is hypotensive or at risk of hypertension. Now, ketamine, everyone's mate. We'll be giving ketamine at 1 to 2 milligrams per kilo as an induction agent. We will have to be cautious with ketamine with increased secretions, so therefore we'll make sure that we have the suction ready. We should give a good suction before intubation. We can also use ketamine to maintain sedation at 0.25 to 5 milligrams per kilo every 5 to 10 minutes. Now paralytic agents, we're going to use either a depolarizing agent or a non-depolarizing agent. Non-depolarizing agents such as rocuronium, they have a longer onset and a longer effect, but they have less contraindications such as succinylcholine. Succinylcholine causes optimal intubation conditions, a lot quicker onset, a lot shorter duration, but it is contraindicated in patients with burns, crush injuries, hypokalemia. Now we'll go through the intubation equipment. So we're going to make sure we've got a BBM connected to oxygen. We're going to make sure that we have a mount for when we get rid of the mask and connect it to the tube. We're going to make sure we've got ET tube, 1 of each size. Right there, you might not be able to see them. We're going to have a size smaller just in case the one we assumed is going to fit in doesn't. We're going to use a gum elastic bougie, also right there. So we're going to use this to pass through the vocal folds during laryngoscopy to feed the tube over. So we're going to try to avoid using the stylet as they can dislodge the tube when they are removed. So we're going to have some tape to tie in the airway, the bite block. We're going to have a syringe to inflate the cuff. We'll check that the cuff can be inflated and lube for the cuff to pass through the vocal folds easily. With the syringe, we're going to inflate with 5 to 7 mils of air. We don't want to go any more than that because we might cause some mucosal ischemia and rebound edema with extubation. We're going to make sure we have a laryngoscope. Make sure the light works on that. Beautiful. Going to make sure we've got some rescue airway equipment if it doesn't go according to plan. So we're going to have 2 MPAs. We'll have Goodell's that we've measured up and some LMAs. One size that we assume is going to fit and one size smaller. We'll also have a crite kit, a front of neck airway kit in case of a surgical airway. So after the tube's been passed, we're going to want to have a listen to the chest to make sure there's equal air entry, the epigastrium silent, equal rise and fall of the chest, end-tidal CO2 showing a good waveform. We're going to make sure we have some vasopressors available. Probably not all that expired adrenaline, but something in case of some hemodynamic instability. All right, so now we're going to go through end-tidal CO2 monitoring. So waveform capnography is a real-time representation and value of expired CO2. It has a number of uses and it should always be used in the anaesthetised patient or the patient with an airway being used and they're being ventilated. So some of its uses include during CPR, it's an estimation of cardiac output and an early indicator of ROSC, and it works for a prognosis of CPR as well. For example, if an end-tidal CO2 is less than 10 and no special circumstances permit, it's probably time to think about stopping. It can be used for confirmation of tube placement and patency, adequacy of ventilation, monitoring patients with raised intracranial pressure to keep the end-tidal CO2 in that narrow range between 35 and 45, and monitoring patients with pulmonary disease and metabolic disease. So now we'll go through some of the equipment that we're going to require. We're going to need a monitor capable of end-tidal CO2 monitoring. This monitor is not capable, but for the sake of this demonstration, it will be. We'll need an end-tidal CO2 detector, either a sideline or an inline. The only difference is an inline, the sample is taken within the circuit, and a sideline, a sample is taken through the line and analysed within the monitor. Next, we'll need a filter, a face mask or an airway adjunct, an LMA, ET tube, whatever you have, and a bag or a ventilator circuit. Alright, so now we're going to go through how to set up the circuit. First of all, we're going to connect the tube to the monitor. So we've got the tube down here, we'll connect it into the monitor in there somewhere. We'll turn it on. Next, put this back there. Next, we're going to attach the airway adapter to the breathing circuit. Right, so we're going to make sure there's a filter between the face mask and the end-tidal CO2 detector just to stop it from gunking up. Then that'll be plugged in to the breathing circuit. So we've got to make sure this is all connected before we start an RSI. We've got to make sure that the end-tidal CO2 tube isn't kinked, it's not bent or twisted, we're not going to trip over it and dislodge it. Once this is all set up, we start using on the patient, you know, whether we got that plugged into an LMA, we've got to confirm the presence of a waveform on the monitor. Magnificent, there it is.